talking about the big project you guys have tomorrow, building a technique chart. Okay? So, when you build a technique chart, essentially what you're doing is trying to learn what the X-ray machine will do for you when you make certain adjustments on KVP, MA, and time. Okay? We'll also talk a little bit about quality control. When it comes to quality, one of the important things is that your job is to create a radiograph that is readable. You have to come up with radiographs that if you show them to me, I can read, that don't show anything that would be overtly a problem when it comes to things like artifacts. I have to be able to read them. That means you need to be able to look at an X-ray and determine if it's diagnostic quality. Okay, that's your job. Then you get that image, then you can give it to me, then I can read it. If it's not diagnostic quality, then what do you have to do? Take another one, which means more exposure, more money, more time wasted. What I find most commonly when people send me X-rays that are not diagnostic quality, I can't read this. What do I know for a fact happened in the clinic? They charge the client for a non-diagnostic image. Is that fair? No. You have to make sure the image is of diagnostic quality. Otherwise, sending it to me for an evaluation or to a radiologist is going to give you less than stellar results. The client is paying for something which is not helpful, which if you look at it is a great way to lose clients. And I've had to tell clients that. They bring me X-rays and they tell me I need to know what's going on. I can't read this. And then they get ticked off, justifiably so, about the clinic that took the X-rays. So you guys have to know how to do this. You don't make a diagnosis off the image, but you have to make sure the image is so a diagnosis could be made, if there's one to be made. The corrections then, you guys have to know how to do that. That's why we've studied all this time on physics of X-rays and the variables that go into it. Now, digital is making this less of a concern. You've seen that at CPE. Those candidates are screwing up as far as their measurements, as far as what they measure, all that. But the image always looks great, right? Well, that's kind of bad. Because sometimes digital doesn't fix it. You can't change it enough digitally to make it diagnostic quality if it's so bad digitally. So even digital doesn't do everything. And that requires that you know what you're doing. It's not just setting it up like some of the guys at CPE. They just luck out. Now, you guys know all about the physics. You know about the tube, the cathode, the anode. You know what the X-ray number change is. It's either due to MA or S. And then penetration has to do with the energy of the photon, or the KVP that creates that. You guys know what density is. Density is the degree of blackness. Okay? When you look in areas that have nothing there, the film should be black. Okay? The thing about this MAS or the blackness, regardless of what I change my penetration to, or the contrast, the degree of blackness will stay the same. You guys know that contrast has to do with the density difference between tissues like heart, liver, stomach, kidney, spleen, okay? The density difference between those is going to be picked up by the way the photons can penetrate those different structures. And so that means KVP. That's what affects contrast. If the contrast is altered, okay, then that's not going to change MAS, even if I change contrast. Now, remember though, KVP does a little bit of changing the blackness, because the same number of other photons are still there. It just makes more penetrating if you turn it up. But generally speaking, higher KVP means lower contrast, because now I can see the difference between all those structures. Okay? Now, when you're looking at hard copy x-rays, your viewer makes a difference, okay? See the difference between these two? That changes contrast. So you have to make sure that your view box is in good shape. The tubes have to be the same kind of tube, changed at the same time. If you change one, because you don't know what that's going to look like when you turn the light on, you got to change them all. Bulbs have to be the same wattage so that you have even lighting across your view box. And then the lens or the plastic cover has to be clean. You don't want stuff stuck on it that when you turn it on you can see shadows. That will show through the x-ray. Positioning is important of the film. Now this isn't positioning the animal, this is positioning the film. There is a standard that is pretty much set. So when an x-ray goes up on the view box, whether it be hard copied x-rays or film, they need to be put on the view box or on the screen the same way, oriented the same way. Okay? So if it's a dorsal ventral or ventral dorsal view, the head is up toward the top of the screen or up to the top of the viewer, so the head is right here. And then the patient's right is on the viewer's left. So, heads up, this is the right side of the animal, this is my left, so when I'm looking at it, it's like I could reach out and shake hands. Okay? That's the way it's supposed to be set on the view box or on the screen. If the right side was over here, that would be wrong. Because when you learn how to read them a certain way, it looks funny. If you put up an x-ray with the dogs on the view box with the head going that way, the first thing I'm going to do is turn it around and put it back where it belongs. So you have to make sure you put it on the screen or on the view box correctly. Should I say that again?
Yes.
You have to make sure you put it on the screen or the view box correctly. Everybody got it? All right. If it's a lateral view, the head and the spine are at the top of the view box or the screen, and the head is going to the left. Okay? It has to be that way. If it's going the wrong way, I'm going to turn it around. Okay? Now, we get to evaluating the technique. When you evaluate technique of x-rays, there are two basic questions that you have to ask. The first question is, well actually let's change that. Let's make it, there is a preliminary question that has to be asked. The preliminary question is, what am I looking at? No, what am I looking at? Am I looking at soft tissue or am I looking at bone? If I'm looking at bone, what do I need to have? High contrast or low contrast? High contrast, because that shows the difference between blacks and whites a lot better. If I'm looking at soft tissues, what do I need? Low contrast. So that should be first one. So if I'm looking at this image here, what am I looking at? I'm looking at bone. Okay, if I'm looking at this, I'm probably looking at soft tissue because it's the thorax. Okay? So, if I'm looking for bone, the first thing I need to know is, do I have high contrast or low contrast? Then I got to start going to the next questions. Okay? The first question is it too light or too dark? That's the first question you ask. Okay? If it's this film, what is it? Way too light. Okay? This one?
Too dark.
Way too dark. Once you ask that question, now you have to figure out, why is it too light? Or why is it too dark? Is it too light because it's underexposed? Okay, that would mean I got to increase MAS or KVP because I need more exposure, right? So, if the film is too light, I need to have increase of MA or time or MAS and KVP. If it's too dark, is it overexposed? Okay? If it's too dark, then I gotta turn one of those down. Everybody see how that works? So then once you've asked that question and answered it, now you gotta figure out which one you're gonna do, MAS or KVP. Got it? Then you're gonna find out which one you're gonna change. And that has to do with the penetration of the film. So the next question is it properly penetrated? Okay? If it's properly penetrated, that means I can see anatomic silhouettes in the film. Even if it's too dark, I can still see the silhouettes. Okay? How would I know if I can see silhouettes if it's too dark? How would I know? If the film is too dark, how do I know if I can see silhouettes of what I'm looking at? Anybody see the little hot light I've got in there on the X-ray table? You step on the pedal and you can really make it bright. Then you can see silhouettes inside there. Does that make sense? So I'm going to look and I'm going to find out, can I see them? Even if the film is too dark, even if it's too light, can I see what looks like that could be liver, that could be the spleen, that could be this and that, the heart versus the diaphragm? If I can see those, the penetration is good because I can see them. So that means if it's if it's too dark, or I can see the silhouettes regardless if it's too light or too dark, then I have to change MAS. If it's such that I can't see the silhouettes, even if I hold it up to a hot light, or even if I look at it just on a straight white background, if I can't see any evidence of silhouettes inside what I'm taking a radiograph of, that means the penetration isn't good enough. So I have to change my KVP. Everybody got it? You're sure? Because everybody gets screwed up on this. In fact, one year, the class took it upon themselves to start interpreting it the wrong way. Everybody got the test questions wrong. Everybody. Because they didn't understand what they were talking about. So you have to make sure you're looking and you understand what the concept of silhouettes are. Like here, I can see diaphragm, I can see a lobe of the liver, I can see the spleen, I can see a kidney right there, I can see the bladder there, I can see the walls of the intestines, okay? I can see the silhouettes there. So if it was too light, but I can see the silhouettes, what do I need to change? MAS. I need to kick up the MAS if it's too light. If I can see silhouettes and it's too dark, turn down the MAS. Okay? Everybody get it? All right. So this is essentially what you're looking at when you're evaluating an X-ray. This is really a simple algorithm. Once I know if I'm taking an X-ray of hard tissue, bone, or soft tissue, now I know what I need to have as far as contrast, then I'm going to ask this question. Is it too light or is it too dark? If it's too light, this side of the algorithm is worthless. I don't need it. If it's too dark, I don't need this side. Okay? Everybody with me? So if it's too light, I go to this side. If it's too light, then I have to ask what? Is my penetration okay? Well, if it's too light, is it very likely that it's going to be over-penetrated? No. So, too light, is it under-penetrated? The answer is either yes or no. Because if it wouldn't be over-penetrated, okay, because then it would make it too dark. Okay? So if it's under-penetrated, the answer is either yes or no. If it's under-penetrated, that means my KVP's wrong. So I have to change my KVP. Okay? So do you see how this works? If you answer this question, you go to one side or the other side of the algorithm. You all are saying that this sounds really good, right?
I feel like you're emphasizing this because everybody gets it wrong.
Everybody gets it wrong.
But it's also easy.
I know.
It should be, because it makes perfect sense if you
Yeah.
follow the algorithm. Okay? And when you make changes, you don't have to change it by much unless it's MA or time. MAS. Up to 50%. Well, if I have my MAS set at 160 and it's too light or underpenetrated, then I have to kick my KVP up. If it's MA, it's not penetrated, or if it is penetrated okay, then I gotta change my MAS by up to 50%. So if it's 160, 50% of 160 is what? 80. So 80 plus 160, I have to kick my MAS up to 240. That's a big jump. But when you look at KVP, it's a much smaller jump. 10 to 15% is all. Okay? To make big differences, visual differences in your films. Okay, so now that tissue type. What kind of tissue am I looking for? If I'm looking at soft tissue, I need to see all sorts of shades of gray. Like a kidney here, a bladder wall right there, the stones in the bladder, intestinal wall. There's even something right there that looks funny. More than likely, that's a stone coming in from a ureter, going to the bladder. Okay? If I'm looking at bone, I need to see blacks and whites. I need to be able to see if there's a problem in the bone. I don't need to see all of the soft tissues around it. Okay, I need to see the bones. So that means I need high contrast. Okay? So first preliminary question, what tissue am I looking at? Soft tissue or hard tissue? Then I have to make the determination on what kind of film do I have. Okay? Now, the purpose of all this stuff is so that we can build a chart that gives you some consistency. The exposure factors will be consistent for the same thicknesses, the same tissue types, which means my results should be really similar. So if I'm taking a radiograph of a pelvis with a dog that has a pelvis that's 14 centimeters wide, the next time I see a dog come in a month later and it has a pelvis of 14 centimeters wide, I should be able to use the same settings on my x-ray machine, right? I should. But remember that technique charts are machine specific. You can't use the technique chart that you guys developed for our machine for a machine down the street, because each machine is different. They have to be developed for the specific machine. And you have to have specific charts for different parts of the body because of the density differences and the types of tissue differences you're looking for. So, if I'm going to use potentially the x-ray machine for really small items, then I've got to have screen and non-screen. In other words, tabletop, which is what? Top of the table, but it's going to tell me what if the grid's going to be in there. I've got to have, I skipped ahead. Grid or table, screen and non-screen. Do we use any x-ray cassettes that don't have screens in them? Yes, dental x-rays. They don't have screens. So when you guys are using dental x-rays, charts have to be completely different. Species, if I took a radiograph of a tortoise versus a cat, and I'm just doing an abdominal film, am I going to get the same results if they're the same thickness? No, because the tissue types, the species, the differences in those species. A bird that's 14 centimeters, that's going to be a big bird, that has a certain centimeter thickness, if I took an x-ray of a mammal that has the same thickness, completely different results, okay? So you have to have charts for all of the different tissue types, different species, and the anatomy in those. So that's why when you look back in the x-ray suite, how many technique charts did you guys see? 4 or 5, right? That's what you guys have to develop. That's what you guys have to develop. Okay, for your own. They have to be for the class of 2025. So that means as soon as you guys get yours developed, or should get it developed, the other technique charts go away. And they're not gonna be there for you anymore. Everybody got it? All right. Now, the chart factors, the things that go into making this technique chart, start with certain things that are constant. And you guys have already learned some of these. The source to image distance. Why does Dr. Cassiopo in radiology make it a point to move that x-ray tube? They have to know, and it has to be constant. That way I don't have to worry about the half-life, not half-life, law of inverse squares. I don't have to worry about that, because remember, if I move the source closer to the image, it changes the amount of intensity. So that gets rid of that potential confounding factor if my source to image distance is the same. Filtration, we already know that's the same, right? Where's the filter? Huh? Between the tube and the collimate, okay? So that's always constant, that never changes. Hopefully processing never changes. That means you gotta know what happens when you process the film. And the grid type, that's embedded in the table, you can't change that. So that's a constant. So those things are pretty cool. We don't have to mess with that much, as long as you get this correct. The things that are variable are the film types and the screen types. Well, we can minimize that potential problem by making sure we use the same kind of film with the right kind of screen, okay? Now, when we're looking at charts in practices, there's basically certain charts that you have to have. First is extremity and skull, okay? What are we looking at primarily if we're looking at extremities and the skull? Bone, okay? But remember, we want really high detail with those. The best way to get detail is to get the grid out of the way. But you can't get the grid out of the way if the animal's really thick, because then you get more scatter, okay? So for extremity and skull, if it's less than 9 centimeters, you don't use it in the cassette tray. You have to put it on the tabletop, okay? So if you look at that, between that, anything less than 9 centimeters, if it's a 3 centimeter foot, I put it on the tabletop. I don't put it in the cassette tray. Okay? Anything over 9 centimeters where scatter is going to be a bigger problem, I put it in the cassette tray. So your skull extremity chart has to be variable, depending on the thickness of whatever it is your x-ray. Okay? The next is an abdomen. The abdomen has lots of different soft tissue densities, which means we need what kind of contrast? Low contrast. But if I have any kind of scatter, that's going to change my contrast. So I got to get rid of any scatter that might screw up my abdomen film. Well, the best way to get rid of scatter is to use a grid. So regardless of thickness for the abdomen, it's in the cassette tray. Okay? Same thing for thorax, because I'm probably looking at soft tissue materials, and any scatter could potentially screw that up. So I have to use the grid. So all thoraxes are in the cassette tray, regardless of thickness. Okay? Spine and pelvis, what am I looking at? Bone. So if I'm looking at bone, what kind of contrast do I need? High contrast. I'm not too worried about scatter if it's really, really small. But if it's really thick, there's more potential for scatter, so now I use the grid. So for spine and pelvis, if it's greater than 9 centimeters, I gotta put it in the cassette tray. If it's less than that, I put it on the tabletop. Okay? Avian and exotics, we don't use grids, and if they're really small, like if I'm gonna take a radiograph of one of the rats, okay? That's really small, so I'm probably not too worried about scatter from the rat, so I can just put him on the tabletop. But what if I'm taking a radiograph of a desert tortoise that top to bottom is this tall, which is probably about 14 centimeters? Now I'm worried about scattering, so now I put him back in the table, okay? or in the cassette tray. Everybody got it? So those are the technique charts you gotta build. All right, so here's how you do it. This is what we'll be giving it a shot on tomorrow, which means we have to have an animal tomorrow. An animal that is about this size, that preferably needs to have x-rays, because then we can actually do it. So, we need to have a 40 to 50 pound dog, okay? You guys have to determine where this is coming from. It's going to go under anesthesia. It's gonna be clear out. So that means you don't have to restrain it. It's gonna hold still. If it's anesthetized prior to anesthesia, what do we have to do? Gotta get blood work done. So whoever brings the dog, whichever dog it is, has to bring it in in fasting, and it has to get blood work done tomorrow morning before lab starts. Okay? And if it's a really nice, happy dog, that makes life a lot easier. Okay? We've got our dog now, our patient. Now, we gotta have the right size cassette. So we use the biggest ones we got. 14 by 17 inch cassette. Doesn't mean we open up the field size to 14 by 17, but that makes sure we're gonna get the abdomen. Then once we've got that dog and we've got the right kind of film, okay, now we gotta take shots, see what happens. Okay? Exposure factors, so we can set this correctly. We gotta start from scratch. So we gotta use Sante's rule to figure out what our KVP is gonna be. You guys know what Sante's rule is, but remember now we're going into the cassette tray, because it's what kind of shot? Abdomen. Abdomen's always in the cassette tray. So that means now we gotta add something more to that, because now we've got a grid in the way. And the grid factor plus Sante's rule gives us the starting point for our KVP. Okay, that's how you set your first KVP for your first shot. MA, you set it to the highest setting possible that your machine will allow. Well, our machine goes up to 400. But we're not gonna set it that high because a lot of machines don't go up that high. We're gonna go to 320 MA. And it's gonna stay there, it's not gonna change, okay, unless we change what we're taking radiographs of. The time is based on the MAS that's needed for the screens we use. Okay? So we have screens, they're in all the cassettes. Each of those has to have a certain amount of MAS for that screen. Well, we know what our MA is gonna be, so now we have to figure out what our time is so we get the MAS that's necessary for that screen. Okay? And this is what we do. If we are using fast screen in our cassettes, then we have to have MAS somewhere between 2.5 and 10 MAS. So if my MA is 320 and I want an MAS of 10, what's my time set at? It's just math. Huh? 0.04 seconds. Is that correct? Is that what everybody got? 320 MA. MA times time is equal to
MAS.
MAS. So if I want an MAS of 10, okay, that's my answer. 320 MA times what equals 10?
I got 0.03.
0.03? Okay, so 0.03 what? Seconds. Everybody see how it works? Okay? If I'm using medium or par speed films or screens, then my MAS has to be between 5 and 12.5. If I'm using slow speed, it's got to be between 30 and 40. Well, this is easy because this is what we're using. So our MAS has to be somewhere between 5 and 12.5. Okay? So now we know how to set KVP. we know what our MA is gonna be, and now we know how to set our time according to what we're looking for, okay? Now, obviously, that grid is in the way. We've got to modify for the grid that's there. Generally speaking, we double the exposure time, that increases MAS, right? That would be helpful, so now we get through the grid with enough photons. Our KVP factors, basically, if we have a grid that's a 5-to-1 grid, we go up 6 to 8 KVP for everything we do. So that means Sante's rule now will be Sante's rule plus the grid factor, which will be 6 to 8 KVP for every single exposure. Okay? If it's an 8-to-1 grid, 8 to 10 KVP. And what does the ratio mean? We talked about it a long time ago in this class.
It's a
How
fraction.
is the ratio determined? The height of the lengths versus the width of the spacers. Okay? If it's a 12-to-1 grid, 10 to 15 KVP. 16-to-1, 15 to 20 kV. Just enough to get the photons that you need to get through the grid. Okay? Well, how are you going to know that?
Read it.
You read it. It tells you someplace because it comes with the table information. So you got to know. Okay? Now, when you're looking at the X-ray machine, fortunately for us, a lot of these things are set. The line voltage means how much voltage is coming from the socket in the wall that actually gets over to the X-ray machine. Fortunately for us now, our machine, we don't have to worry about that. But let me give you a hint. With our little portable machine that goes outside, you have to fix this. Okay? The SID we keep constant. We know what it's going to be. The exposure then is going to be KVP is equal to Sante's rule plus the grid factor. MA is going to be 320. And time is whatever is required to make our MAS for the screens acceptable. In this case, because we use par speed screens, has to be between 5 and 12 and a half. Okay? Everybody with me? Because you got to do this tomorrow. Okay? Now, generally, the screen and the film are the same. We know that. That's already set. The grid, we look it up on the machine. In the paperwork on the machine, it tells us what our grid ratio is. Then we have to take a test exposure because you are going to create KVP and MAS. You're going to take a shot of the animal that's asleep on the table. And then we've got to process the film. As long as our processor is working properly, hopefully this will work, okay? Now, once you've got it done, you've taken your x-ray, now you have to evaluate the film. And so now you have to go through and ask the questions. Well, what are we taking an image of when we're doing our technique chart? Abdomen, so what kind of contrast do we need? Low contrast, okay? Then I'm going to ask my questions. Is it too light or is it too dark? If it's too dark, I go to one side of the algorithm. If it's too light, I go to the other side. Then, if I have to make adjustments based on these things, I make an adjustment. Then what? Take another shot, see if it fixed it. What if it didn't? You do it again until you get the shot that you think is perfect. Okay? Then once that perfect shot is done, then you can make the rest of the chart up by simple mathematics. Okay? So you're going to make one number that's going to be based on all of this stuff. Then after that, you just have to change things around based on math. Because our MA is going to be constant, we don't have to worry about that one. Time depends on the thickness to get through for our screen. So the only thing that we're really changing is what? KVP. This is a variable KVP technique chart. Okay? So all we got to do is change KVP, plus or minus for each centimeter in thickness change. So if I have a 14 centimeter exposure and I got the right perfect exposure for it, if my next subject or my next width is 12 centimeters, what do I have to do? Decrease what? By? So 4 kVp. And you could just plot that on the chart mathematically. Everybody got it? Okay, so here's an example. Our film speed is par speed. And this is CSN's machine, so you might want to pay attention. Okay? The grid ratio of our machine is 8:1. The SID, we know we're going to keep it about 40 inches. And that doesn't change. Our patient, you're going to find a male, or a dog, could be a female, 40 pounds, whatever, abdomen, and 40 pounds needs to be not obese weight. Okay? It has to be a pretty normal looking dog. If the abdomen was 12 centimeters, okay, we know it's going to be in the grid because it's abdomen, right? Okay, so that means I need to use this.
I have a question really quick for tomorrow's lab. Does anybody have a dog other than me? Because the only one that I have is about 75 pounds overweight.
Way too big.
So
We need to find a dog that fits this category.
I have a 12-pound dog.
Isn't, what's her face, Zelda pretty fit?
Yeah, but she
I feel like she's more than.
I don't.
40 pounds.
If she's the right size and not obese, that might work.
Okay.
But we gotta have one,
She's probably our only candidate then.
okay? So you
Okay.
guys are gonna have to work with her. So if that was our case, if this is our dog, okay, abdomen's 12 centimeters. Sante's rule says 2 times 12 centimeters plus 40 is Sante's rule, right? And then our grid factor, it's an 8:1 grid. So how much do we need to add for an 8:1 grid?
80,
What does it say?
6
What?
to 8.
8
6
to
to 8,
10.
so we're gonna go with 8. So our starting KVP is going to be 72 for 12 centimeter abdomen. Okay? Our MA, we're gonna keep it here. In order to know what the time is, I need to have some kind of a chart, a matrix chart that helps me out to figure this out, okay? The time, again, has to do with this matrix chart. And here's a matrix chart, okay? So if I look at this, 320 times 0.08 seconds equals 2.5 MAS, right? But how many MAS do I need? For my screens, I'm using par screen speeds, or screens. 5 to 12.5. So that means this won't work, because that's only 2.5. This isn't gonna work, this won't work, but this one would. So that would be a place to start for my time. But then again, I could go clear up to about here. So anywhere between here and here, I can set my times to that. So I know what I'm going to have my time set at. Well, if I'm changing MAS or time, what am I changing on the film? The density. If I'm looking at something I want to have really good density, it would probably be better to go to the top end of my time, right? So I can have an MAS somewhere between 8 and 10. So my time setting is going to be here and here for that 12 centimeter abdomen. Okay? Everybody see it? So that little matrix chart makes your life so much easier. You don't have to sit and do all the calculations yourself.
That starting MA that's the highest setting possible.
That's 320. Because
Okay, so
remember,
that's
that's
where
what
we
we
got
said
that.
we're gonna do.
Okay.
Okay? We're not gonna go to 400, that's what all these 320s mean, okay? So, here's our medium or par screen film. This is probably a little high. I would probably wanna go right in here for abdomen, for medium screen. Now, if I'm gonna do a skull and extremity, what kind of clarity do I need? Really high clarity, so I need low contrast. I want my MAS to be about 5. Okay? That's just something we're gonna use. For the thorax, what's in the thorax that's not in the abdomen? A lot of air. So that means that's one of those densities that's in the 5 basic densities that I really can't see, okay? So what I have to do is I have to decrease my MAS. 50 to 75% MAS decrease from abdomen. If my abdomen MAS was 8, what should I do for my thorax? Make it 4, or a little less. For pelvis and spine, because now there's nothing in there but bone and muscle, I'm gonna kick it up because I want more clarity, or not more contrast. I want a high contrast, more clarity, which means I need to have less KVP, but more MAS, so I can kick up my MAS. And for abdomen, we're gonna be somewhere in here, so somewhere around 8 to 10 is what is ideal. Okay, so we know what we gotta do here. Everybody got it? Now, sometimes we have to make modifications, especially if scatter is a potential problem, okay? If we want to minimize scatter, I have to decrease the potential penetration, okay? If time is a concern, well, when would time be a concern if I'm taking an x-ray of a dog? Huh? Moving, okay? Moving's probably a better word. So what is more important when it comes to movement, to stopping motion? Huh? What's constantly moving in the body? Constantly. The heart. So what do I need to do with the heart if I'm taking radiographs of it?
Stop it.
How do I stop it?
Wait, what?
On the x-ray.
So faster speed.
Faster speed.
You list them on the table.
All I have to do is turn my speed so it's slow or faster, and that will stop any motion, right? So that's when I have to make modifications. If it's excessively thick, really thick, I gotta increase the number of photons. So I gotta kick my MAS up. If there's pathology involved, for example, I'm taking a radiograph of the abdomen, but the abdomen is full of fluid. I know I can get through it because it's only a certain thickness, but are all of the photons gonna get through now because there's so much fluid? Not necessarily, so I gotta kick up my MAS to make sure I get enough through it. Really fat, I gotta do the same thing, increase my MAS. If there's a contrast procedure, I'm putting in radiographic contrast agent into the patient, I gotta kick it up because I gotta get the photons down to the film. So I'm gonna kick up my MAS. If it's a neonate, really young animal, it's gonna get through because most of the neonate is what? Water. What's the 5 densities, basic densities?
Air.
In order.
Give me a second.
Air.
Oil,
Fat,
fuck,
water,
metal is the last one.
bone, and metal, okay? So if it's mostly water, I should be able to have enough photons to get through. So I turn down my MAS. Okay, so those are when I have to make adjustments to my technique based on the situation. Okay? Everybody get the process for building a technique chart. Okay? So we gotta have a dog that's gotta be normal size, small enough so that when we take the abdomen's on the film, not half on this film and half on another film. Okay? And we're not taking a whole dogogram, we're just taking the abdomen, so we're gonna collimate to the right level. Okay? Then you're gonna start taking shots based on your calculations. Then you're gonna start to evaluate the shots. If you didn't make the right one on the first one, you're gonna take another one. And you're gonna write down on the film in a Sharpie what your settings were. Then, once you guys have, in your opinion, the best film you can get, guess what you're gonna do? You're gonna take it to Dr. Pease and have him evaluate it,
No way.
and have him give you any suggestions.
How do we do that?
You gotta go talk to Dr. Pease.
Where is
Do we
he?
have?
We have to wait until CPs.
Yeah.
Alright. Well, I walked in the window and I was like, next CP, I'll probably have to picture for you in the class.
Okay?
What it was?
Then we're gonna come back, we're gonna make any final
Like man
adjustments,
Monday.
and then you gotta build your technique chart. Not just one, you have to build one for skull and extremity, thorax, abdomen, and pelvis and spine. Okay? Everybody got it?
Yes.
Okay, because remember, after you guys are done with the lab tomorrow, those other technique charts are gone. They're going to be taken away. So you can see how this is a class project,
Yeah.
not just one or two of you in the class. I promise this is gonna be really important to you in the future.
Oh.
So
Okay.
if we do it wrong, we're just gonna have trouble the rest of the year.
Exactly.
You don't let us do
That's
it
why
wrong.
we're taking it to
I'm
Dr.
not,
B's.
you guys have to do it.
You don't let us do it wrong though?
I don't have to worry about it. You know, you do it. Okay? That's exposure. That means our machine has to be doing the right thing. We want to make sure that the radiographs we create are good, and we want to decrease extra films. We don't need to take more films, because the quality of our machine isn't putting out correctly. So we have to make sure we do certain things to make sure that happens. Quality assurance, then, are activities that are done to assure that quality control is effective. So certain tasks we have to do, like preventative maintenance on the X-ray machine. We do quality control tests. We have calibration. We have that machine calibrated every year, so that when you set it and you push the button, you know that what you set it to is what's coming out of the machine. And then in-service education. This is a big problem in that veterinarians are lazy for the most part. They don't teach new people coming in. Who taught you guys how to run the X-ray machines where you're at? The techs. They did. Where did they learn it? From the tech. Where does it end? There has to be a good education process so you know and understand the machine. That's why you guys have spent so much time on our X-ray machine, getting to know the machine. Okay? There's a purpose for all that stuff you've done. Now, quality control, again, those are the activities that are done to assure what we create is good quality. So some of the things we can be done, we can send out for somebody to come in and do it, or we can do it ourselves. Like unobjective data accumulation. For example, what's our SID? How do we know that when we set that machine to the tabletop, it's actually 40 inches?
Because we measured it.
Get a ruler, get a tape measure, and find out. Is that what it is? That's a quality control thing. That can be done very easily. How about perpendicularity of our X-ray tube? When you turn it to the side, how do you know it's perpendicular to the table? How do you know? You use a level. You get a level, you put it on top of the tube, and you look for the little bubble. If the little bubble is not in the center, it's not perpendicular to the tabletop. Does that make sense? And then locks, those buttons that you push, when you let go of it, does it hold it in position? Or has somebody broken the magnetic interlocks because they try to force the tube? Okay? Field lights. When you turn on the X-ray field light so you can see how big the X-ray beam is going to be on the table, does it work? That's easy to tell. Push the button, see if it works. There was I think I told you about the clinic where the field light didn't work anymore. So in order to make sure they got the image on the film they wanted, they opened it up all the way. Well, yeah, they got it, but what else did they do? Unnecessary exposure to patient and to people. The size. If you set it to a certain size based on the scale, is that what it really is? How do you know? You measure it. There is a 2% tolerance based on whatever it says. That means it's gotta be within 2% of what it actually says on the machine. Okay? Well, you need a tape measure to do that, or a ruler. Other things, if you can set the table to an angle, you gotta find out, is it set at the angle? Well, ours doesn't have an angle indicator. So that would be kind of tough, but in order to know if it is the right angle, you guys remember geometry, right? Use a protractor and a ruler and figure it out. That's just basic junior high school stuff. The view box, if you want to make sure the light coming out of the view box is the right number of, what's the word I'm looking for? Not ohms. I can't remember the unit of measure. Well, yeah, ohms could work. Anyway, you just get a meter, a light meter, and it'll tell you on the meter how much light's coming out of it. It measures it. The light field and the X-ray field. If I turn the little light things on the collimator and the light field gets bigger and bigger, how do I know that the X-ray field, the actual X-ray field, is the same as the light field? Would that be important to know? Yeah. So to do that, we do something called the 9-penny test. Okay? And then you find out if it's within tolerance levels. Screen film contact, you already did that. Remember the paper clips last week on the film? And the little piece of gauze that was in there that raised the film and the screen from the screen? It was blurry, right? So if I did that and didn't put any gauze inside it, just put a bunch of paper clips on the screen or the cassette, and then took an X-ray and then looked at all of them, make sure there's no areas where it's blurry, that tells me the screen film contact's gotta be good. Okay? And then darkroom techniques, we've already been in there. You look for light leaks. Okay? You look for all the stuff that goes inside there. Those are all quality control tests. That's one of the things we can do after we get your technique chart built. So you guys got a lot of work tomorrow. Okay? Everybody got it?
Yep.
Okay, and I don't care as long as the dog that comes in is a normal body size, it's not obese, about 40 pounds. We can fudge that between 40,